Good evening. I'm so excited to be able to talk to you about something that's near and dear to my heart, newborn hearing screening and follow-up best practices. I would like to start by saying I'd like this to be quite interactive. I don't have planned questions necessarily to ask of you, but I certainly want you to get practical information from this session, so please don't hesitate to ask questions at any point during the presentation. So the objectives for this evening are, I'd like you by the end to appreciate the evolution in newborn hearing screening, to understand the newborn hearing screening and follow-up process, to understand how factors that place infants and children at risk for late onset hearing loss impact follow-up and long-term outcomes. I'd like you to be able to appreciate the tools that are available for assessing auditory function and hearing in pediatric patients. And some of that will be some overlap with what was covered last week, but I'd like to go into a little deeper dive so that I want to make sure that you all understand how we manage these infants and children. I'd like you to appreciate the role of the medical home in surveillance, and to understand the relationship between intervention outcomes in the pediatric patients who are deaf and hard of hearing. So this was mentioned last week, but I want to reiterate it. Why do we worry about newborn hearing screening? Well, permanent hearing loss occurs pretty frequently. The numbers are kind of variable depending on whose paper you read, but 1 to 3 or 1 to 5 of every 1,000 otherwise healthy newborn infants have hearing loss. But it's much greater in the NICU graduates, so as many as 2 to 4 of every 100 graduates of the newborn intensive care nursery have hearing loss. And as you heard last week, hearing loss can be caused by genetic and environmental etiologies. And just because there is a known environmental cause doesn't mean that there cannot also be an overlying genetic cause. We know that the negative impact of hearing loss has been well established, including negative impact on language development, social and emotional development, literacy and academic development, and vocational options. Certainly, as you can appreciate, if you don't learn how to use language, that's going to impact you socially and emotionally. But also, if you don't have language, you can't learn to read. And if you can't read, you really can't progress in terms of academic development, which would limit your vocational options. So because of those things, early identification and appropriate intervention are critical. Now, newborn hearing screening has been around for a while. Marion Downs, who's thought to be sort of the mother of audiology, pediatric audiology, began advocating for infant hearing screening in the early 1960s. And back in those days, we didn't have a lot of options in terms of how to screen infants for hearing loss. She certainly appreciated that hearing loss in children would have these negative impacts, but we didn't have a lot of technology. In fact, a lot of times early hearing screening was nothing more than making a lot of noise by a newborn and watching for a startle response. The Joint Committee on Infant Hearing, or JCIH, was established in 1969 and charged with developing accurate methods for identifying hearing loss in infants and young children. And originally, that group included the American Speech Language Hearing Association, the American Academy of Ophthalmology and Otolaryngology, and the American Academy of Pediatrics. And they mostly just worked on trying to advocate for and identify ways that we could test children, and developed a lot of position papers over the years. Certainly the development of auditory brainstem response testing and otoacoustic emission technologies were important contributors to our ability to make progress with identifying hearing loss early on. In my early career, even when we had some technology, screening was only completed by audiologists on newborn intensive care unit babies. And they were based that screening was based on factors that placed them at risk for developing hearing loss. And the list of risk factors has evolved over time, which I'm going to show you in just a minute. So in terms of the progress of the Joint Committee, their first statement in 1970 actually said that mass screening was not justified due to lack of procedures that were available. And the 1972 statement first outlined risk factors for progressive hearing loss. In 1982, the statement added bacterial meningitis and asphyxia as risk factors. And also during this time, they added some additional groups into the Joint Committee. So over the 30 years, the JCIH has explored the complexities of hearing loss and its impact on the development of speech and language, as well as looking for better methods to identify and serve infants and their families. The 1994 statement endorsed, but did not recommend, which I think is an important distinction, universal detection of hearing loss. They endorsed identification by 3 months of age and intervention by 6 months of age. It was not until the 2000 statement that the Joint Committee actually recommended universal newborn hearing screening before discharge and promoted an essential system of tracking and screening and tracking kids with hearing loss. Each of the statements became more explicit. And I just want to let you know, just to back up for a minute, that this notion of universal newborn hearing screening was quite controversial in the early years. The concern was that with a high-risk system of doing newborn hearing screening, we tracked those kids, so we knew who had risk factors and we could follow them over time. The concern was that if we went to a universal newborn hearing screening program and we did not necessarily follow all children, we might miss children with late onset hearing loss. And so I think you'll see from the information that I'm going to provide that this has been an evolution of thought, and the technology that we have available to us has made it easier. But we would not be able to have a universal newborn hearing screening program that is successful without an infrastructure at the state level to keep track of these children so that we can minimize the loss to follow-up. So universal hearing screening was initiated in the 1980s, and by the mid-1990s there was consensus that all infants should be screened prior to discharge, that there should be universal detection of hearing loss by 3 months, and that appropriate intervention should occur no later than 6 months. And we refer to that as the 136 guidelines. By 2001, most states had mandated universal newborn hearing screening or EDI programs, and it's important to note that even today, there's a lot of variability in what occurs in different states. For example, some states only require screening in towns of a certain size or in hospitals of a certain size. And so it really is still not the case that all children in all states are screened at birth or prior to discharge from the hospital. In 2007, the statement was very much more explicit, and it was the first time that they included neural hearing loss and regarding auditory neuropathy spectrum disorder, which we're going to talk about a little more. It also differentiating screening recommendations for well babies versus the newborn intensive care unit. Specifically, the 2007 guidelines recommend that babies who are healthy, well babies, are screened initially using otoacoustic emissions, and that the babies in the NICU are screened using automated AVR. We're going to talk about both of those techniques in a minute, and then I'll tell you what we do at the University of Michigan, because we don't follow the recommendations, and I'll let you know why. Also, the guidelines said that you should rescreen bilaterally, even if there's a unilateral referral. It removed the differentiation between congenital versus late onset hearing loss risk indicators. The risk indicators were expanded. And one of the main differences with this particular position statement was it recommended that professionals who are engaged in the diagnosis and follow-up of infants and children with hearing loss have particular expertise in working with children with hearing loss. There are a lot of people who are audiologists and other professionals who deal with hearing loss who are not necessarily well equipped to deal with children with hearing loss, and particularly children who have comorbidities such as neurodevelopmental disabilities and autism. So this position statement recognized that if this system were going to be successful, the people who were going to be involved with it needed to have this special expertise. So in terms of early detection, hearing detection and intervention, there are a variety of components. We've talked about universal newborn hearing screening, but that's just one piece. Another important contributor based on the 2007 guidelines is the concept of the medical home. And the medical home, or primary care, is an important contributor to the success of this program, not just for children who fail a newborn hearing screening, but for those who pass and who need surveillance. I mentioned to you that there was a lot of controversy early on about whether we would miss children who had risk factors for progressive hearing loss if we went to universal newborn hearing screening and didn't have a mechanism to track everyone. So the concept with this 2007 recommendation is that family-centered, accessible, comprehensive, coordinated, compassionate care that is culturally effective will be provided in the medical home. And we'll talk a little bit more about the role of the medical home relative to identification of children with hearing loss. Another important component is diagnostic audiology. And again, as I mentioned, this should include professionals who have special expertise with dealing with children. Early intervention is a really important piece as well. Last week, we mentioned that we need to really be responsive to what the families want in terms of communication options. But in any case, regardless of what they choose to do, getting the child and family engaged with early intervention support is really critical to success. Also, family support is important. Diagnosis of hearing loss has a profound impact on parents. As with any permanent condition, they're confronted with the notion that their child is going to have this condition throughout life, and it has a way of changing sort of their vision of their child. I think every parent imagines their child to be this perfect individual with life-long opportunities for success, and we all have this idea about how they're going to grow and what they're going to do. And when you introduce the diagnosis of hearing loss, it can be devastating. So family support is a really critical component of the EDI program. And then, of course, as I've mentioned, tracking and data management is critical. So in terms of EDI relevance for the medical home, as I mentioned, audiologists with expertise in the evaluation of infants and young children should be the folks who are providing hearing assessments and intervention with children who do not pass a newborn hearing screening. Children with risk indicators who pass the screening should have at least one diagnostic evaluation, and the 2007 guidelines specify that should occur between 24 and 30 months of age. and that more frequent evaluations would be indicated for some populations. We'll talk a little bit about why I have some concerns about that time period. And specifically, if we wait to follow up until a child is 2 years old or older, there can be substantial consequences for a late identified hearing loss. The guidelines also recommend that young children who fail the speech and language portion of the medical home global screen or those with parental concerns should be referred for audiologic testing and a speech and language evaluation. Now, one of the other important points about these recommendations is that infants with confirmed hearing loss should be offered a genetics consultation. I mentioned before that even if we know that there's an environmental factor that contributed to the hearing loss, that doesn't mean that there isn't also a genetic possibility. And as was mentioned last week, a lot of hearing loss in children, both present at birth and delayed onset, can have genetic etiologies. And a family history of hearing loss is not necessarily required in order for there to be a genetic etiology. Some kids with recessive genetic disorders are the first to present with the hearing loss. So even if you think you've done a good history with asking about family history of hearing loss, it doesn't mean that that's not a risk factor for kids that are identified with hearing loss. In addition, we recommend evaluation by a pediatric otolaryngologist for all kids with confirmed hearing loss, and also referral to a pediatric ophthalmologist. And the reason for that is that there are quite a number of conditions for which vision coincides with the hearing loss. And for some of those conditions, it's helpful to know what the status is of the eyes. And in some cases, the vision loss can be what presents early. If you think about it, if a child is going to be deaf and blind, the decisions that you might make about intervention would be quite different than if you suspect that a child is going to have normal vision. So referral to a pediatric ophthalmologist is definitely recommended. And then for all infants, regular surveillance consistent with the American Academy of Pediatric periodicity schedule is recommended, which would include looking at developmental milestones, looking at auditory skill development, paying close attention to parental concerns, and evaluation of mental ear status. Sadly, we still see children who present themselves into our clinic at 2 years of age or older where parents have been mentioning concerns for quite a while and where the primary care physician discounted their concerns. So I think parental concerns is one of the most important risk factors for hearing loss. So according to these guidelines, I mentioned this periodicity schedule, all infants should have an objective standard screening of global development with a valid assessment tool at 9, 18, 24, and 30 months of age. Again, or at any time if the healthcare professional or family has concern. And infants who do not pass the speech and language portion of a medical home global screening, or for whom there's concern regarding hearing or language, should be referred for speech and language evaluation and audiology assessment. Now, one of the really important things about this early hearing detection and intervention is that information gets communicated efficiently and promptly. So that includes individual hearing screening information, and any follow-up audiologic diagnostic testing should be promptly transmitted to the medical home and to the state EDI coordinator. In Michigan, we're fortunate to have a very well-coordinated EDI program at the state level. And I will tell you that if parents neglect to schedule follow-up testing for a failed newborn hearing screening, they will get frequent letters from the state encouraging parents to schedule follow-up testing. Additionally, I think they will hound the hospitals and other facilities to communicate with them if they don't hear back from a child who's failed a newborn hearing screening. I guess I should indicate that hospitals are required to send the information about the newborn hearing screening right away. So the EDI coordinator knows which infants have failed the newborn hearing screening, and they then can follow up both with the birthing hospital if they're not getting follow-up information, and with the parents and the medical home. Families should be made aware of all communication options and available hearing technologies, and that information should be presented in an unbiased manner. As was discussed last week, I think it's challenging as an audiologist who's well aware of the amazing technology that is available to help infants and young children who have hearing loss make speech audible to them. But there are families who choose not to go that route. And so we try really hard to let them know about all of the options that are available to them in an unbiased manner. Informed family choice and their desired outcome should be guiding the decision-making process. As I mentioned, states need to have an infrastructure in place in order for this program to be successful. So they need to have a data management and tracking system that would be part of an integrated child health information system in order to monitor the quality of the EDI services and to provide recommendations for improving systems of care. In our state, hospitals get on a quarterly basis a report of all of the children that were born in our hospital, how many children failed their newborn hearing screening, how many of them we reported that they had diagnostic testing as follow-up, how many failed their newborn hearing screening. We get all of that data on a quarterly basis. And we get it not just for our institution, but for all of the hospitals and health systems in the state of Michigan. So we have a pretty good tracking mechanism in our state to monitor these children, which is important. There also needs to be an effective link between health and educational professionals in order to ensure successful transition and to determine outcomes of children with hearing loss. That is really important for planning and establishing public health policy. I want to let you know that the EDI program is funded by and authorized by the federal government, and it has not been reauthorized for a while. So there is currently legislation in both the House and the Senate to reauthorize EDI. And so I'd encourage you to look at that legislation and consider letting your senators and representatives know about the importance of co-sponsoring this legislation. It would be a shame if the federal government did not reauthorize EDI, which would potentially undermine the success of this program that's made so much headway. There are some challenges to the medical home model. Specifically, there's a relatively low incidence of severe hearing loss, which results in individual pediatricians having limited exposure to children with severe hearing loss. Additionally, there's limited physician education on all aspects of the program and on hearing loss. And there are some misconceptions about the success of universal newborn hearing screening. I think it's really important, as I mentioned, to appreciate that lots of children can pass their newborn hearing screening, and without the surveillance of the medical home, we may miss hearing loss that is due to an etiology that we don't know about that creates a risk factor for progressive hearing loss. Sometimes the medical home is challenged in getting the results of the newborn hearing screening. in our facility, I think we do a really good job, but that's not true of all hospitals and of all states. There are some questions about retesting in the office. One of the requirements for universal newborn hearing screening is that you use the same technology to follow up with the child that was used in the hospital. So for example, if a hospital uses automated ABR to screen their babies, and the child fails, a follow-up has to occur in a place using that can do that same technology. So that means that they need to be referred to a pediatric audiology facility that has the ability to do auditory brainstem response testing. I'll give you an example of how that plays out in our own community. Quite a number of the hospitals in Michigan use automated ABR, and St. Joe's Hospital in Ann Arbor, for example, has no ability to do follow-up diagnostic testing. So we wind up at the University of Michigan seeing all of their failures. So what you don't want to do is to have somebody who's screened using one technology and then having to follow up using another technology, which can create some challenges for the medical home. Another one is being able to provide support. Another is working with early intervention and community agencies. I'm not sure that all primary care physicians are equally well versed in what the resources are out in the community. And from my perspective, that just means that the onus is on us as pediatric audiologists who are involved with these children to make that first attempt, and also to connect, to let the primary care physicians know what we're recommending and what the resources are that are available. And then another challenge is time constraints and financial constraints. So these are the risk factors for neonates. It includes family history of childhood hearing loss. Again, sometimes people, when we ask about that, they say, well, my so-and-so has hearing loss, but they're not really sure when it occurred. And in some cases, the parent may say, well, my husband has a hearing loss, but I'm pretty sure it was due to an infection when he was little. So even though we try our best to get a handle on whether there's a family history of childhood hearing loss, we're not always successful in doing that. Again, which is why the medical home is so important. Congenital perinatal infection is another risk factor. In the old days, rubella did horrible things to hearing and then was pretty much eradicated. It's concerning to me that some of these perinatal or prenatal infections have resurfaced because of immunization changes. But, rubella was a frequent cause of hearing loss back in the 1980s and earlier. There are other non-bacterial fetal infections such as congenital cytomegalovirus and herpes. CMV is getting a lot of attention these days, and I think there's a lot of controversy about how best to manage screening for CMV in the newborn population. Because it occurs so commonly as an infection in adults and can be benign, you really have to know that a child is infected at the beginning. Otherwise, they can get exposed to it, and then the test isn't very valuable. CMV can cause, in addition to hearing loss, lots of other neurodevelopmental disabilities, and they can be delayed onset. So you can have a child with CMV who passes their newborn hearing screening and winds up being profoundly deaf by the age of 2 or 3. Another risk factor is any craniofacial anomalies. We see a lot of kids who have cleft and palate with other craniofacial anomalies, and that is automatically a risk indicator for hearing loss. Extreme low birth rate is another one. And those were the original risk indicators, and then these others were added later. So extreme hyperbilirubinemia And pretty much what we're talking about is high enough bilirubin that it's criteria for exchange transfusion. We don't see that very much. I think that they are doing a better job of managing hyperbilirubinemia. Bacterial meningitis is a risk factor, and that particular risk factor, when it results in hearing loss, also impacts how quickly we move towards cochlear implantation, because bacterial meningitis can cause ossification of the cochlea and negatively impact outcomes with cochlear implantation if we wait too long. Severe asphyxia is another one. Prolonged mechanical ventilation, and also exposure to ototoxic medications greater than 5 days. We see a lot of infants who are treated with gentamicin in the NICU. And what's interesting about that is there's a general lack of awareness about the dangers of gentamicin in general, particularly to the vestibular system. But also, we had a conversation with the neonatologist in our place, and some of these kids they might get gent for 4 days and then stop, and then they might either get readmitted for something or later get gent again. And so I think we don't have a very good mechanism to track children who get multiple exposures to ototoxic medications that may not be more than 5 days consecutively. And then syndromes associated with sensory neural hearing loss. I will tell you that the numbers of varieties of syndromes that we see is exploding. I think genetic testing is making it a lot easier to identify constellations of symptoms, and so there are lots of syndromes that we see associated with sensory neural hearing loss. There are also risk factors for infants. So the ones I just talked to you about are for neonates. In terms of risk factors for infants, as I mentioned before, parental concern is at the top of the list. Also, as the picture indicates, kids fall and hit their heads, and head trauma is a risk indicator for these kids. The presence of neurodegenerative disorders, and then finally childhood infections that are associated with sensory neural hearing loss, for example, measles and mumps. And again, we didn't see those diseases for a really long time, and now unfortunately, because people are not necessarily immunizing their children, I think we're starting to see that again. So now we're going to talk a little bit about auditory development, which is, I think, one of my favorite things to just talk to people who are not audiologists about, because I think it's really cool. So the human cochlea is fully developed at birth, and actually it's fully developed before birth. But the central auditory pathways are not fully ready to go at birth. And maturation takes quite a period of time, probably a decade or more. And there's plasticity that continues throughout life. So it's really important to consider how hearing loss will negatively impact the development of auditory skills. The tuning of the auditory system to speech begins very early. And we think that fetuses are able to hear in utero by about 25 weeks gestation. But it's not really clear how that experience impacts speech perception because of the environment. So, you know, the infant is floating in fluid, and so probably a lot of the high frequency information in speech is filtered out just based on the fluid dynamics and the way sound works in water. But the suprasegmental information, which includes intonation and rhythm, transmits pretty well to the fetuses. We do know that newborns and fetuses are able to discriminate their native language from a foreign language and their mother's voice from that of another person, which I think is pretty amazing. We also know that infants attend preferentially to infant-directed speech over adult-directed speech. And there are a number of critical periods, the first of which begins when they're trying to master the sounds in their own language. We know that babies can discriminate all of the sounds of the world in the beginning. So if you did a discrimination task with a child who will be a native English speaker, they would be able to not only discriminate the sounds that are salient in English, but also those that are salient in Japanese or Chinese, even when that's not a language that they're going to be exposed to. So they have this ability, amazing ability, to broadly identify the signs, identify and discriminate the sounds of the world. But sometimes between 6 months of age and a year, they become selective listeners. I just want to pause and say I think it's remarkable that we can even know what these babies can do. So the people who are doing research in this area are phenomenal and creative. So we know that infants appear to become sensitive to the rules about how segments or phonemes are ordered. Around the same time, they show sensitivity to stress patterns of words. And that before the first birthday, babies with normal hearing and normal cognition are able to extract all of the salient features of English while listening to fluent speech, which is pretty remarkable. So if you have degraded auditory input due to hearing loss, they're going to have to rely on their general cognitive skills to try and help compensate. And you can imagine there's all this early development that's going on with fine-tuning the auditory system before the first birthday. So even a mild hearing loss during that period is going to have a negative impact. There are large multi-center studies underway to compare the language learning outcomes of children with mild to severe hearing loss to those of their normal hearing peers. And we'll talk more about that in a little while. Next, we're going to talk about the actual techniques that we're able to use to conduct newborn hearing screening. So there really are two types that I mentioned before, but I'm going to give you more information about them so that you can appreciate what we're doing. The first class is evoked otoacoustic emissions, and there are two types, transient OAEs and distortion product OAEs. And these responses provide information about outer hair cell function. So they give us some information about how the cochlea is functioning. Unfortunately, these procedures are confounded by excessive debris in the ear canal or by fluid in the middle ear space. So although it's recommended as a first-line screen in well babies, there's a fairly high false positive rate using this technique, particularly if you're trying to test them during their first day of life, when they might not have even had a bath and their ear canals may be full of debris. The other option is automated auditory brainstem response testing, which provides information about auditory system function through the level of the brainstem. It does not give us information about processing of sound, and according to the Joint Committee recommendations, this is recommended for use in the NICU. Now, in practice, many hospitals, including ours, use automated ABR for screening of all infants. Not all places use the same intensity level. We happen to screen using a broadband stimulus, which is called a click, presented at 30 decibels relative to normal hearing in each ear. And the options are either to use an insert earphone. As you can see, this little baby has, these are transducers, and then there's an insert earphone. Or you can see in this one, there's a circumoral earphone. And basically what we're doing is we're recording the nervous system's responses to these auditory stimuli. The machines that we use have algorithms in them that are looking for a particular pattern of response. So the algorithm knows what the response should look like, and when the baby's response looks like what the algorithm says it should be, the machine will indicate a pass. If the response doesn't look like what it should look like, the machine will say that it's a refer. Now, some machines enable the person who's doing the testing to look at the responses in addition to taking the pass or refer outcome. And I think that's really important for a quality program because machines aren't perfect. And what you don't want is for the baby's noise, if they're moving or whatever, to wind up looking like it's a response when in fact there's not a response. We are more concerned about missing babies that have hearing loss than we are about having a high refer rate, but that's just our bias. And you know, with any test, whoever is administering the test is going to have a bias one way or the other. So you have to make a decision whether you prefer, which kind of errors you prefer to make. Do you prefer to over-refer and have it be a slightly more expensive program, or do you or would you prefer to under-refer and risk missing patients who have a disorder? Our bias clearly is that we would prefer to over-refer. So the outcomes of this test are pass or refer, and the stipulation is that you have to pass both ears in order to pass. Now, I do want to let you know that in our hospital, we have 5 technicians who are very well trained, have been doing this for a long time, and are quite capable. And they stay with the baby while the machine is doing its thing. So they know how to place electrodes well. They know how to place the inserts well. They know when to come back if the baby is fussy or the mother is busy doing something. And so for us, we are very careful about what's going on when we're actually doing the screening. And our program is administered by audiologists. In some places, newborn hearing screening falls under the purview of nursing. And the technicians or whoever's doing the test, and sometimes it's nurses who do the test, are not necessarily well trained. And so in those places, the outcomes might be poorer. There is a hospital that I know of who does do automated ABR, and the technicians hook the baby up and then leave the room and let the machine run. And again, that's not ideal because you would have no way of knowing what factors might have interfered with the validity of the testing that's going on. So I think it's really important for whoever's doing the testing to be well trained, for them to keep an eye on what's going on. The other thing is not everybody uses the same intensity level. So we use 30 dB relative to normal hearing. Some use 40. If you use a higher level, you're going to miss kids with mild hearing loss. So in terms of timing, the goal is to screen all infants prior to discharge. We do a pretty good job of that in our place. Again, we have technicians that do the screens, and they're available 7 days a week because we have them work 10-hour days. They're generally there from pretty early in the morning until, early evening. So they're able to get all of the kids for the most part. We have one person who focuses their energy on monitoring the status of the NICU babies because in the NICU, we want to conduct the screening as close to discharge as possible. There's no point in screening really fragile babies. We will only screen twice, and so the goal is really to get them when they're medically stable and as close to discharge as possible. So it takes some effort to keep track of these kids who are there for quite a while so that we don't miss them because we don't want to miss screening them before they're discharged. Babies who refer in one or both ears are scheduled for follow-up diagnostic testing. And in our place, we typically do that within 4 to 6 weeks. We prefer to let them have a little time to grow after discharge and to let any fluid that that's in their middle ear space post-birth clear before we do the diagnostic testing. So for that reason, we prefer to wait 4 to 6 weeks following discharge. There are some variations from typical timing. So as I mentioned, the NICU babies who are hospitalized for long periods of time, we try and wait to screen them. We do get some pressure from the neonatologists from time to time to do a screening because they want to know. Some of these children have comorbidities, and so sometimes if they do, the neonatologist may want to know whether hearing is also a factor that's been identified. If we have a big congenital heart program in our place, and so we have a lot of kids who have both heart problems and hearing loss. So sometimes the physicians really want to know what's going on with them. We'll screen them when they ask, but we'll only screen twice, and so we'd rather wait. We can't have them be transported down to the clinic for diagnostic testing until they're medically stable. And it's kind of tricky to do a great test in the NICU because of all of the electrical interference with the equipment. Also, one of the factors that's important to think about is if an individual is very fragile and they have hearing loss, it's not likely that we're going to do anything to manage the hearing loss until they're medically stable. So if you think about sort of cost benefit, yes, it would be important to know that there's hearing loss, and yet for some of these children, there's so much going on, and the parents can be completely overwhelmed. And adding a diagnosis of hearing loss on top of everything else that's going on may just put them over the top. So, you know, our bias is that we'd rather wait until they're medically stable, till the parents are able to cope with the other factors that are going on that are causing this baby to be in the NICU before we do our hearing testing. And we do ask physicians in the NICU to contact us. By us, I mean the audiologists in our group, if they have specific questions about hearing or a particular reason that they want to address hearing testing prior to discharge. This is a cute little baby. We like it when they're sleeping like this when we do our follow-up testing. So we do we're very careful to contact parents before they bring their baby in to have the follow-up testing. We actually have an audiologist who does this testing, make the phone calls to remind parents of what to expect. And since we've been doing that, we have a much greater likelihood of them actually following the instructions. So we repeat the ABR testing in a sound booth. And the difference between the screen and what happens in the diagnostic testing is that in addition to using this broadband stimulus with the click, which is used in the newborn hearing screening, we're also going to use tonal stimuli in order to try and get sort of a physiologic audiogram, if you will. Parents are advised to bring the baby to the clinic hungry and tired. That can be torture to parents, and I've had mothers say that it was one of the hardest things they ever did because the child may be crying all the way there. But it really makes it so that once the baby is fed, natural sleep is generally possible. There's nothing magical about the baby needing to sleep from a nervous system perspective. The reason that we want them to be sleeping is that the electrodes that we use are not smart, and they are going to pick up any electrical energy that is close to them. Muscle creates muscle movement, muscle activity is an electrical signal that's much bigger in amplitude than is the little nervous system response that we're trying to record. So if a baby is moving, we might not get the response that we're looking for, and that can result in it looking like a child having hearing loss when in fact it's just the noise that's causing us not to be able to see this little teeny neural response. I want to talk a little bit about the distortion product otoacoustic emission and how we do it. I think that may help you appreciate the elegance of the measure and how it contributes to our ability to know more about what's happening in a baby's ear. So what we do with OAE testing is to play two tones into the ear canal that have a particular relationship in terms of the frequencies of them. And these two stimuli cause a distortion product. So they actually create a response in the ear that's at a different frequency, which is the otoacoustic emission. And it's actually the otoacoustic emission that we are recording and looking at. And the response that we're looking for, in order to determine whether there is a response, we are presenting these two tones at two intensity levels that have a particular relationship to one another. And we're recording the noise floor, so like the baby's movement. And then we're recording this little teeny response. And what we're looking for is a difference between the noise floor and the response is at least 6 decibels. The response that you see on the slide is great because the noise floor, which is represented by the green diamonds and the line that connects them, is really low. And it's a pretty robust response as well. You might imagine that if the noise floor were higher and you had that same response, you might not be able to get this difference of 6 dB that we're looking for between that noise floor and the response. So DPOAEs provide a useful adjunct to ABR testing in the follow-up period. So they provide specific information about outer hair cell function. For OAE testing, the child can be awake, so it's less sensitive to muscle movement than is the ABR. And we insert a probe tip into the ear canal, as you can see in the picture there. So if a baby wakes up before we're able to get the all of the tonal stimuli presented during our ABR testing, we can use OAEs as an adjunct to give us this frequency-specific information that we need. I want to mention tympanometry. I know this was presented last week, but I wanted to help you understand really what we're doing when we do tympanometry and why it matters what the probe tone frequency is. You can see we can do TIMPs on itty-bitty kiddos. What we're really doing with tympanometry is to put a probe into the ear canal that has 3 openings. One is connected to a manometer that changes air pressure in the ear canal. One generates a tone that is played through a loudspeaker into the ear canal, and that's called a probe tone. And for adults, we use a probe tone that's really pretty low frequency, 226 hertz. For babies, we have to use a high-frequency probe tone because of the flaccid nature of their ear canal. And then there's a microphone that records the sound pressure level in the ear canal. So we vary pressure in the ear canal, and we're recording sound pressure level as a function of these changes in pressure in the ear canal. And the machine derives a tympanogram from these measurements that we're taking. In an ideal world, you want the maximum compliant point of eardrum to be the same as ambient pressure. So the eardrum is going to be most compliant at ambient pressure for a normal tympanogram. And this is just a depiction of the different tympanometry types. I don't expect you all to memorize or know this. I just think it's likely when you're working in interdisciplinary teams moving forward that you may encounter a child who has had audiologic testing, and you may see results of a tympanogram. So I just want you to generally be aware of how we record this tympanometry results. So a type A tympanogram means that the maximum compliant point of the eardrum is at ambient pressure, which is denoted at the 0. If you have a stiff eardrum, it would be the AS that you see there. And if you had a really hypermobile eardrum, which could be if there's an acicular chain discontinuity or something, you may have a very deep but still A-type tympanogram. A type C tympanogram occurs when there's negative pressure in the middle ear space. So if your eustachian tube is not functioning correctly, if it's not opening as often as it should, then you can get a vacuum forming in that middle ear space, which would result in this negative middle ear pressure, which can impact hearing loss. It can also be a precursor to having sterile fluid in the middle ear space. If the eustachian tube isn't opening like it's supposed to, fluid can be drawn out of the mucous membrane that's lining the middle ear space, and it can result in there being sterile fluid collected in the middle ear space, which would result in a type B tympanogram. It doesn't have to be an ear infection. It can be sterile fluid. But because the eustachian tube is connected to the back of the throat, it's pretty easy in infants for germs to migrate from the back of the throat into the middle ear. And so this fluid can become infected. So complete follow-up diagnostic testing includes an auditory brainstem response test with clicks and tonal stimuli. When we're doing the follow-up testing, we're going to look for normal responses at 20 decibels relative to normal hearing for both clicks and tonal stimuli. I mentioned before that when we screen at 30, but when they come in for testing, we really want to make sure that their hearing is within the normal range. So if time allows and the baby's sleeping, we'll do testing at octave frequencies throughout the frequency range that's most important for speech and language development. If there's an indication of hearing loss, we will also do bone conduction testing using click stimuli in order to ascertain how much of the hearing loss is due to a sensory neural component, so the inner ear or nerve, and how much of it may be due to a problem such as fluid in the middle ear. Again, as I mentioned, if a baby wakes up before we're able to do all of that testing, we can use distortion product otoacoustic emissions in each ear at a higher frequency range in order to make sure that there's no hearing loss in that frequency range that's so important for being able to hear the very soft, high-pitched speech sounds that are needed in order to hear and understand speech and for speech and language development. We also will do tympanometry using a 1000 hertz probe tone, as I just mentioned. We also will test for the middle ear muscle reflex ipsilaterally. So by presenting a loud sound into the ear, we're looking for a change in stiffness in the eardrum, which gives us some indication about how the nervous system is working. So the goal of this follow-up testing, if there's hearing loss, is to be able to initiate intervention if needed. So if a child has hearing loss where hearing aids or other devices would be appropriate, our goal is to be able to take this ABR and OAE testing if done, and to fit hearing aids based on these results, because it will be quite a while before we're able to get behavioral audiometric thresholds from these children. So I want to talk about the options for measuring hearing and auditory function. There are really two categories. One is physiologic measures of auditory system function, and we've already talked about the tools in our arsenal to do that. It includes acoustic emittance testing, which is tympanometry and acoustic reflexes. In addition to the ipsilateral acoustic reflexes that I mentioned, we can also do contralateral reflexes, which would mean that we are measuring the changing compliance of the eardrum in one ear and presenting a loud sound to the other ear. That gives us a little more information about the nervous system function. Another physiologic measure is otoacoustic emissions, which we've already discussed, and auditory evoked potentials. So these are really, really valuable tools to give us information about how the auditory system is functioning, but they really don't tell us what a child hears. for knowing what a child can hear, we need to rely on behavioral tests of hearing. And as we talked about last week, that can include pure tone, air and bone conduction threshold measures, and speech audiometry. What's important for you to know about how we do this testing with children, or what I'd like you to know and appreciate, is that generally speaking, we're using operant conditioning paradigms in order to get the responses that they need. So there's nothing magical really about the response that we need to use. The response has to be something that the child can do, so something that's in their repertoire. It needs to be what follows the response is really what's important, because we want to increase the likelihood of the behavior occurring again. And so it needs to be something that's reinforcing to the child. And so testing is individualized based on the needs of the child and their abilities. I think we talked last week a little bit about some of the techniques that we use, but I wanted to give you more information about that just so you can appreciate how challenging it can be and sort of some of the tricks we have in our arsenal. So VRA, visual reinforcement audiometry, is used with little kids. So starting by the age of 6 or 7 months, we can take advantage of a child's likelihood that they will make volitional head turn responses when they hear a sound. So they're going to localize to the sound. And then we pair that sound with an animated toy or a video image. So you can see on the screen there's a little box that has a toy in it that's going to move and light up when the tester makes it do so. So the response that we're looking for is a clear head turn to the right or to the left. And eventually we'll start out pairing that, the head turn response will reinforce with this animated toy or video image. And then the goal is to have the head turn response occur only in the presence of the sound. That can take a while because sometimes babies will see that lovely animated toy or video image and they will make a lot of head turn response even when the sound is not present. So in order to be able to test hearing using this technique, you have to wait long enough so that you're sure that the baby's only turning the head in response to sound and not just because they're curious about seeing this video image. Now, the assumption with this particular test technique is that the video image is reinforcing to the child. Clearly, this would not be something you'd be able to do if the child is blind. For slightly older children, we use something called play audiometry, and this is useful with children who can sit and engage in play. The child's taught to make a response to sound, and there's, again, nothing magical about the response. These are just 3 examples of activities that kids are doing. If you come visit our clinic, you will see that sometimes our sound booths look like a disaster area after a child's been tested because there may be plastic balls all over the floor and pegboards and all kinds of things. So, if they get bored with one particular task, then you can move on to some other task. You're still going to use insert earphones usually or circumaural earphones when you're doing play audiometry. You can also use this technique to look at how a child is performing with hearing aids. So the reinforcement could be praise. It could be a tokens. I used to use the token economy a lot. Have a child pick out a prize that they wanted to work for and then get a token with every correct response. You can use food if there's no contraindication for that. So the response can be varied, and the important thing is that the response should not be so much fun that the child's going to want to do it even when there's no sound being presented. We can also use picture pointing tasks to do speech testing. We can look for speech thresholds. So this is an example of a SPON-D board. We present 2-syllable equal stress words and look for threshold with these words, with this response. Of course, it's really important to make sure that the child has these items in their vocabulary. So before you would do threshold testing, you would make sure that they could identify each of these items before you start testing. And we actually use iPads in our clinic for this purpose now. We mentioned last week a condition called auditory neuropathy spectrum disorder, or ASD. And I just want to review this for you because it's a relatively new phenomenon that's been identified, and it has special implications for how we follow these kids and what we do in terms of management. So ASD is characterized by the presence of responses from the outer hair cells and normal cochlear amplifier function. So in this case, they would have present otoacoustic emissions, but their auditory brainstem response would be abnormal, and they would have absent or abnormal middle ear reflexes. So the presence of this condition is why we do automated ABR testing in our newborn screening program. If you think about the recommendations of the Joint Committee to use otoacoustic emissions for well babies, you can see based on what I've said so far that these babies, even with ASD, would pass screening with otoacoustic emissions. However, we don't want to miss these kids, and I think the rationale behind the recommendations is that the likelihood of ASD is much higher in the NICU population than it is in the well babies. But in our own experience at the University of Michigan, we have plenty of examples of children who were healthy newborns who wind up being identified with ASD. So for that reason, and our own bias, as I mentioned before, that we don't want to miss any kids, we do ABR screening on all of our children. Most patients with ASD have bilateral symptoms, although the function can be asymmetrical or unilateral. And in these patients, speech recognition is generally poorer than expected based on pure tone thresholds. And we think it's because there's a problem with neural synchrony. It's likely that there are lots of mechanisms and etiologies for ASD. And if you think about the auditory pathway, there are lots of junctions, and there could be a problem to occur at any of those junctions. So it could be a problem with mechanical transduction of the inner hair cells. It could be a problem with the synaptic junction between the hair cell and the cochlear branch of the eighth nerve. It could be the cell bodies, the nerve itself. Some patients have no known etiology or other neurologic abnormalities, but some patients have peripheral neuropathies associated with it. And an example is Charcot-Marie-Tooth disease. In some folks, if we don't pick it up at birth, actually the peripheral neuropathy may be the first thing that's identified. And infants with neonatal abnormalities, including kernicterus, which results from very high bilirubin, prematurity and anoxia have been reported with ASD. And I'll just mention that some of the kids who have it as due to kernicterus can resolve, but typically if it's going to resolve, it will resolve within the first year of life. So we had a nice lecture last week that included management, and I'm just trying to reinforce the things that you heard last week and to give you some visual images of what we're talking about. So when permanent hearing loss is present and when the parent goals for their child is spoken language, we put hearing aids on as soon as possible, and certainly before the age of 6 months. We're fortunate to have a loaner hearing aid bank. We got donor funds to purchase hearing aids that we have. So we can put a hearing aid on a baby as soon as they're identified, if that's the route that the parent is interested in taking, even while we're waiting to get insurance authorization for their own hearing aids. As was mentioned last week, the goal of amplification is to make audible all of the important elements of speech. And if you think back to the speech banana that you saw last week, the biggest challenge is to make all those very soft, high-frequency sounds completely audible for children, particularly with severe hearing loss. It's important for you to know, you're going to be working in interdisciplinary teams, and you're going to see these children with hearing loss who may or may not have other comorbidities. The reason it's so important to intervene early is that children with hearing loss need exactly the same amount of exposure or experience with sound to develop receptive and expressive language as their normally hearing counterparts. So time lost is time lost. You can't get it back. So if we wait to put hearing aids or whatever technology on a child until they're a year old, and you think back to what I said to you about all of the fine-tuning of the auditory system that happens before the first year of life, during the first year of life, you can't get that back. I mean, that child has missed the opportunity to go through that fine-tuning. So it's really critical for everybody who's going to be working with children with hearing loss to understand and appreciate that whatever the delay is before intervention, that time is gone and it cannot be replaced. Carissa mentioned bone conduction hearing aids. I just wanted again to give you a visual to go with it. These children in the picture all have microtia. You can see that their ears not formed fully. And for them, their inner ear may be completely normal, but we've got to bypass this missing outer ear system in order to get sound to them. And the best way to do that is to vibrate their skull with a device. So you can see that all of these children are wearing a device that is affixed to a headband, and that's typically what we do. These devices can be implanted, but not until they're at least 5 years old. This is another picture of cochlear implants, which we talked about last time. Cochlear implant criteria are changing rapidly, and I heard today that where children used to have to be completely deaf in order to meet criteria for implants, now they're really looking at kids with even moderate to severe hearing loss. Can't overestimate the importance of a team, including a speech-language pathologist. Their inclusion on a team for a child with hearing loss helps facilitate better outcomes. And they need a speech-language pathologist who specializes in managing children with hearing loss. One of the really cool things about having the speech pathologist on the team is that they can help us explain communication options and provide some guidance in choosing an option that's most appropriate for the circumstances of the parent. I will say that one of the key important components of successful use of an implant and even hearing aids is parental motivation. And so, we know that some of our families are quite challenged to even come to appointments. And so we have to take into account individual factors of the family and the child in helping to encourage choice of modality and communication options. They also can help establish full-time use of hearing aids or cochlear implants because they are another part of the team that can enforce what we're already saying. They can encourage families to follow up with audiology. They also can help us determine when and what speech sounds are audible or not, but also intelligible to the child. So we have to have audibility, but in addition to audibility, we really want these sounds to be intelligible. So for example, if a hearing aid or a cochlear implant can make both S and SH audible to the child, but the child can't distinguish between those sounds, they're not going to develop language normally. S is a really key sound if you think about it in terms of grammar development. So being able to distinguish an S from another fricative sound is important. They also help track speech and language development or progress and provide guidance on how much intervention is warranted and if the family should consider a different communication option. So the goal is 3 months progress in 3 months time, and if they're not making 3 months progress in 3 months time with intervention, then it's likely that a different option may be recommended. And they also can help to develop the family's understanding of and confidence in working with their child. You might imagine that just having a child come to speech therapy once a week is not going to do a whole lot for speech and language development. Most of the work is done by the parents. And so it's a speech pathologist that really can help the parent develop the skills that they need to communicate with their child in an appropriate fashion, but also to feel confident in their ability to do so. I think when hearing loss is diagnosed, a lot of times parents sort of forget what their normal inclinations would be in interacting with their child, and the speech pathologist can help return them to a more normal state in terms of communication. Again, this is just a reminder of some of the milestones that are important. And again, time lost is time lost. So if you wait 2 years to put on hearing aids, or if we don't diagnose a hearing loss till 2 years, then that child is still going to have to go through these same developmental stages, but just later than normal. And you might imagine that eventually you get to the point where it cannot possibly catch up. There are a number of variables related to success with implants or any other intervention. One is the age of appropriate intervention. We've been stressing early intervention. I heard again today that 18 months seems to be the magical time for cochlear implantation. If a child is implanted before that date, they're likely to do quite well, but if it's delayed, they're not going to do as well as they would with early intervention. Also, some of our kids have really abnormally formed cochleas. So if you're inserting an electrode array into the cochlea, you need to make sure that there's sufficient cochlear status for this to work. We do have some children who don't have a nerve, and clearly if there's no nerve to stimulate electrically, that's not going to be a viable option. Cognitive status is also a variable that's worthy of consideration. And as I mentioned, parental motivation and involvement. And finally, the educational placement should be able to support auditory skill development and spoken language if one is considering intervention that involves the desire to have spoken language be the outcome for the child. There are other variables to consider, such as the permanent or transient nature of auditory neuropathy or hearing loss. ANSD is one of those tricky disorders because those children can appear to have normal hearing from an audibility perspective. So in other words, if you put them in the sound booth and you test them with pure tones, they can have completely normal audiograms in spite of the auditory neuropathy. And I mentioned that they have this abnormal ABR. So if you think about our normal way to decide whether an infant has a hearing loss is using the ABR. And if we can't use that to tell us what a child's ability to hear is, we have to wait until they're slightly older in order to get behavioral testing on them, which can delay our ability to know what they're actually hearing and make treatment tricky. The tricky thing about auditory neuropathy, particularly in these kids that have normal audibility, is that the parents think they hear. And so we have parents who look at us and think that we're not being honest with them when we say that their child has a disorder, because they see their child responding to sound and they don't understand that they can respond to certain sounds, but that doesn't mean that they're going to be able to process speech stimuli normally. Clearly, comorbidities and their impact on testing and management are factors to be considered. We have children who are severely disabled who are not able to respond behaviorally in any meaningful way to sounds. And for those children, sometimes we wind up taking them to the operating room to try and get a better handle on what they're hearing. Again, parental preferences regarding management is really, really important. We believe wholeheartedly in family-centered care, patient family-centered care, and we try very hard not to impose our desires on the family. I have mentioned the impact on anatomy, on management options. Clearly, if there's no auditory nerve, then that limits what your choices are. And then sorting out various contributing factors to development, like cognitive status, other neurologic problems, behavioral and neurodevelopmental issues, and family dynamics. So we talked about the need to monitor for late onset hearing loss. We talked about the medical home. So if you think back to the guidelines that we talked about, they recommend that a child who passes the newborn hearing screening but has a risk factor should have at least one diagnostic audiologic assessment by 24 to 30 months of age. Again, if a child has a risk factor that for progressive hearing loss and we wait till they're 2 and we find hearing loss, and we have no idea when that hearing loss occurred. A lot of times parents will notice that something's not right by 2 years of age because the child's not talking like they should be. But then again, we've lost time. So I'm not sure that the 24 to 30 months of age recommendation meets what I would like to see for kids. And then early and more frequent assessment may be indicated for children with CMV, syndromes associated with hearing loss, children who have received ECMO or chemotherapy, and when there's caregiver concern. Now, what we do at U of M is for children with risk factors, we completely don't follow the recommendations. We see those kids every 6 months until they're in preschool, so till 48 months of age. And we use assessment tools based on the age and the developmental level of the child, as I mentioned. So I mentioned the concerns. If we wait until they're 2 or older, then there's a delay in identification if the first monitoring occurs then, which would have a negative impact on speech and language development if the hearing loss is undetected. And review of our data suggests that over half of kids were identified before the age of 24 months. So we can't determine the timing of the hearing loss if they're identified later. By what I mean by our data, when we surveil these kids at 6-month intervals, most of them that will develop hearing loss have acquired the hearing loss before the age of 2 years. As I mentioned, caregiver concern is a really important reason to do diagnostic testing. As kids get older, parents and physicians are more likely to be aware that things aren't progressing as they should and refer them. We've talked about this recommendation, and I just would like to get your impressions. So, you know, one of the rationales for the sort of Joint Committee recommendations is that it reduces the number of monitoring appointments, which may be easier for the family. It may create less confusion for parents about the recommended protocol. So I guess that's a positive. On the other hand, if we don't see them frequently, then identification can be delayed. And as I mentioned, that can be a problem. I have some thoughts about what might help, but I'd be interested in hearing from you all about, you know, what thoughts you might have given the information that we've talked about, the importance of follow-up, and how we might work as interprofessional teams to make sure that there is appropriate surveillance of these children. And I'm not talking about the kids who have failed newborn hearing screening. I'm talking about these children who pass their newborn hearing screening but may have risk factors for delayed onset hearing loss. So I'd like to hear from the trainees about any thoughts that you might have about how we could perhaps create a system that would be parent-friendly but would avoid late onset hearing loss, thinking about the medical home.
So I think one thing, I know we're doing hearing screenings at certain age groups in schools. I think one thing that could help for these kids that are at higher risk factors, you know, have risk factors for progressive hearing loss, is maybe doing yearly school screenings. I know ideally it would be nice to have these done more routinely at pediatricians' offices, but I know they also have a lot on their plate and a lot to do. So I think maybe adding more years of screening into the schools would be helpful.
I think that's a great idea for school-age kids. I think, you know, what I was really trying to get at was whether anyone had any ideas about how we can avoid the problem that we still encounter of having children who are 2 or 3 years old show up on our doorstep for an audiologic testing who have meaningful hearing loss and who are not talking. So it remains a challenge. And perhaps, you know, just having you all appreciate this as you're interacting with your interdisciplinary, interprofessional teams, that will help. So I think that it's important to know when to refer to audiology. Whenever there are concerns about hearing or speech and language development on the parts of parents, family members, school personnel, or significant others. Also, when a child's development is lagging behind the expected trajectory. So I mentioned before that these Joint Committee recommendations call for regular surveillance at 9 months and 18 months. So if that's really happening, then ideally the physician would notice that the child's development is lagging. Also, when school performance is not what is expected or changes, so that gets to what Jaynee was talking about with school-age children. And also when a child reports having trouble hearing. So when in doubt, refer. I mean, I think it makes me really sad when parents or children are reporting challenges with hearing or concerns and are not being referred to the appropriate personnel.
Hey, Dr. Handelsman, Ramsey has a question.
Okay.
He says, are there rating scales that can screen for indicators of hearing problems?
I'm not sure what he means by that.
He says, to clarify survey-based behavioral indicators that parents can complete that may flag possible difficulties with hearing-related functioning.
Yes, there are. There are questionnaires that can be utilized. And in fact, a lot of the information that we get, even to monitor performance when we're doing intervention for hearing loss, is based on parental report. The question is whether primary care physicians are aware of or are utilizing those things. Okay. I want to let you know about an exciting addition to our team. 2 years ago, we hired the mother of a child with hearing loss to join our team in pediatric audiology as a patient family centered care coordinator. We had this vision that we knew that we could help connect families with the resources that they needed in their community and with educational resources. But we had the vision that it would probably be more effective if we had a parent of a child with hearing loss who could participate in that effort. And so 2 years ago, we were able to hire Jen Wilcox, who is on our team. And she is perfect because her child failed his newborn hearing screening. She didn't follow up initially like she should have, but soon enough, and he had a progressive hearing loss, so he initially had hearing aids and was followed in our clinic, and now has bilateral cochlear implants. He's doing beautifully. He's 6, I think, now, and he's doing well. But what's really cool about having her as part of our team is that she can make contact with parents of newly identified kids with hearing loss and talk to them from a parent perspective. And she has also brought the parent perspective into our clinic. So not only does she talk to people, parents on the phone, she also, if we're struggling with talking to a parent who's not really sure what to do or isn't sure if they're ready to go pursue cochlear implantation, even if the child's not doing well with hearing aids, she can come in and talk to them from a parent perspective, and it's been really great. The other thing is she's established an online group of parents that we can use to provide guidance, that can provide guidance to us on issues in our clinic. Something as simple as, you know, if you're going to have an appointment with audiology and an appointment with ENT on the same day, what's the maximum amount of time that you would want in between your two appointments? And if we told you that there were these really cool activities that you could do for free in Ann Arbor while you're waiting, would that impact your decision about how much time you would be okay with? She's also working to establish an in-person parent advisory council. The goal, I think, is to have parents actually involved in some of the decisions that we're making in a real way, to serve on committees, and we're working on that. As I mentioned, she makes the initial contact to parents and newly identified children and participates in clinic visits. So it's been really cool. It's been interesting to see the slow sort of adaptation of the physicians and others in the clinic to the value of having her in our clinic. And now she's also working with families of children with tracheostomy, which have complex care needs. So slowly but surely, people are starting to realize how important it is to have her in our clinic. I do want to mention outcomes. So there are longitudinal multi-center studies underway to look at language and literacy and academic performance in children with hearing loss of varying degrees. Carissa provided you with a wealth of information in terms of the resources that she posted for you last week, which is why I didn't post any additional ones. All of the resources that you need for this topic, the topics that we're talking about today, are in the reading materials that she provided to you for last week's session. So I would encourage you to take a look at some of the things that are there. It used to be that we compared children with hearing loss against children with hearing loss. And we said, well, if we do this intervention, are they doing better than children with hearing loss who had this other intervention? But that's not the case anymore. The expectation now is that children with hearing loss, with early identification and early and appropriate intervention, should be able to have performance that's commensurate with their normally hearing peers. And so that's sort of the goal. What's interesting is to see these longitudinal studies that really have looked at how kids are performing. And there have been a number of studies. There's a special issue of the Journal of the American Auditory Society that has a lot of the outcome research from the groups that are working on that. Mary Pat Moeller has been one of the main contributors to the field, and she's partnered with several other people to really do a long-term look at how kids with mild, moderate, severe, profound hearing loss do over time on these metrics. And we know that by age 6, if we intervene early, they can be on par. Sadly, the data are not uniformly great for children. I heard her speak recently about her most recent data, and she was talking about which degrees of hearing loss were doing best. Kids with cochlear implants who are good performance do great because they have audibility across the range of frequencies for all of the speech sounds that they need to develop language, providing everything else is equal. But kids with hearing loss are not uniformly doing well. And what was interesting to me is that the kids with severe hearing loss and the kids with mild hearing loss are doing equally poorly. which doesn't make a lot of sense. You would think that children with mild hearing loss, because it's really easy to put a hearing aid on a child with mild hearing loss and make all of the speech sounds, all the speech elements audible. But what happens with mild hearing loss is that it's more challenging for parents to appreciate the need for a hearing loss, amplification, because they can hear sounds, because the children can hear environmental sounds. Parents are likely to be in denial of there being really a problem. And it's interesting, hearing aids these days do data logging. So it's possible for the audiologist to know how many hours a day the children are actually wearing their hearing aids, which is useful information. So what they found in these longitudinal studies is that children with mild hearing loss are not wearing their hearing aids very long. The recommendation is that kids with hearing loss who are using hearing aids or cochlear implants wear them all waking hours. That's the goal. But we find is that the kids with mild hearing loss are wearing their hearing aids only under very specific circumstances. And so they're not getting consistent auditory input, and they're not getting exposure like they should to the normal elements of speech. So they're not developing language in a way that they should or would if they were wearing their hearing aids. The kids with severe hearing loss are struggling because even with good hearing aid technology, it's difficult to get enough amplification in the high frequencies where these very soft consonant sounds are located for the children to be able to hear them consistently. And so, again, if you can't hear S, you're not going to hear plurals. You need to hear word endings in order to develop grammar, and that can have a profound effect. So, so the kids with severe hearing loss are not doing so well, and the kids with mild hearing loss are also not doing so well when we look at these long-term outcomes with speech and language. So we've got a ways to go. The kids with moderate hearing loss, where we can provide good audibility, are doing better, but they're still not doing as well as their normally hearing peers, and they seem to fall off as academic material gets more complicated, more difficult. There was a study published in Pediatrics in 2006 that looked at primary care physicians and their knowledge and attitudes about newborn hearing screening. And I think this is relevant if we're relying on the medical home, which is the primary care physicians, to help us with surveillance. So the data suggested that there was a high level of support among primary care physicians for universal newborn hearing screening. But there was variability in their perceptions of when follow-up was appropriate. So most of them, more than 70%, said that follow-up testing should occur before 3 months of age. And almost 2/3 indicated that hearing loss could be confirmed by 3 months of age. So that's really good. Although a lot of them did not know that you could put hearing aids on babies. 2/3 of the primary care physicians thought a child with sensory hearing loss should be referred for earlier intervention by 3 months of age, which is pretty exciting. But interestingly, when they were asked to talk about who they referred these children to, if they had a baby in there that they were taking care of with sensory hearing loss, they referred to ENT before referring to audiology or before referring to speech-language pathology. What that tells me is that audiologists and speech-language pathologists need to do a better job of making primary care physicians aware of what they can contribute to the team when working with children with hearing loss. So in summary, we're doing a really good job with screening of newborns. Based on the 2014 CDC data, if you look at all of the states, 91 to 100% of infants are screened. The percentage of kids diagnosed before 3 months among failures, including normal hearing, it varies across state from 1% to 74.2%. So, as I mentioned, there's not, we're not doing equally well in all of the states of the country in terms of managing this. And in Michigan, our rate is 29%, which is not great. We have a pretty high loss to follow-up or loss to documentation rate. It's 34.4% according to the more recent data. Again, that's not where we'd like to be. And of kiddos with hearing loss, about 65% of them are receiving early intervention. Again, we want to flip that. That means that 35% of them are not. And that's, again, we prefer not to be, there's opportunity for improvement. And then of these kids with hearing loss that's been identified, almost 24% of them are lost to follow-up or lost to documentation. So again, we have some ways to go. One of the challenges, I think, for this is some of the factors that these individual families are confronted with. We have kids that we diagnose whose parents don't have the wherewithal to even come in for follow-up appointments. We have parents whose own language skills are not normal, or where their social situation is complicated. We do the best that we can in trying to help them deal with these things, but I think if you have a family that's dealing with whether they have enough money for food and whether they can get their children to school, let alone to the doctor's office, consistently keeping a hearing aid on a child may not be the top priority. And that's the reality of what we're confronted with. And then if you add on comorbidities, we see some kids with a lot of things going on health-wise. And so again, if a parent is worrying about their child's ability to survive, hearing loss may not be at the top of their list. So some of these data, I think, reflect the challenges that we're faced with in terms of the social situations. There also are cultural situations. There are some cultures that where it's devastating to think that their child has any disability, and they hide it from family and from others. And so for those individuals, we have families that say, yes, I want my child to talk, spoken language is my goal, but they just can't follow through on the recommendations that we make, even related to hearing aids, and certainly not to implantation. So those are real factors that negatively impact our ability to follow through with these children, and in turn the children's ability to do well. So we're making progress. We're screening almost all babies now, which is great. Not in every state. In Michigan, we're doing a great job. Ours is very high. At the University of Michigan, our loss to follow-up rate is very low, but we have the resources to do a good job of following up. We have our own database that we keep, and we are able to track folks, but there's still a lot of work to do. And then the medical home is a critical component for success. So I would thank you for your attention. I think if you're interested in one spot shopping for information about the things I've talked about, the CDC website is a great place to start, and I've put the hyperlink there on the slide. Also, the American Speech Language Hearing Association has lots and lots of information about newborn hearing screening and follow-up, hearing loss in general, balance disorders, all kinds of things. Most of that information is available to people who are not members of the American Speech Language Hearing Association. It's not behind a firewall. So I'd encourage you to check it out. A lot of it is written in a way that is very clear and understandable, even for people who have very little knowledge or understanding of hearing or speech and language disorders. So with that, I ask if there are any questions.
Okay, great. Thank you so much. As a parent of a daughter with Down syndrome who also has mild to moderate hearing loss, depending on which ear we're looking at, I had a lot of thoughts, and thank you so much. I think this is an excellent presentation. In consideration with utilizing the medical home and how we can get out this information more to parents, physicians, I'm wondering if there can be some type of educational materials that can possibly be utilized in the waiting room of medical homes, pediatricians, utilizing a care coordinator to pass along this information for looking for signs of possibly hearing loss. I mean, I understand we don't want parents freaking out and rushing every single kid in for hearing tests, but that's just some of my thoughts. I'm thinking on that. And thinking about what you said about the issue with having cooperation from parents and getting hearing aids in children. I struggle with that with my daughter she's 12, on a constant basis, and it is difficult. I think we've decided she has some sensory issues, and as I think it was stated last week, when the hearing aids, they magnify all sounds, and that can be very irritating, I believe, for her. So it is sometimes a constant battle because she did not start wearing them until 2, and then the hearing loss has been kind of fluctuated way back then anyway, and they're like, then we didn't need them, then we had 1. So it wasn't like she was just used to wearing them from the get-go. Another thought on that too is the cost of batteries for hearing aids. Even if you have Medicaid or Children's Special Health Care Services, when we go to Audiology, they give us so many batteries, but I run out and they're very expensive even for me. So I know if they're very expensive for me, they're probably hard, especially for families who are in that, poverty level or even above at that federal poverty level, what is it, up to 140%. So I wonder how much it is even educating parents that maybe the schools can be providing some of this, because our school district did not believe they had any responsibility in providing hearing aid batteries, at least for her during the daytime, but I've heard from others that it can happen. So I think that's something to think about too, is even maybe talking to parents. Is this a struggle? Because I think getting the hearing aid batteries, it can be a struggle for many families. And then I guess some of my last thoughts being, I know for us, she did fail on, I think, the left ear in the NICU. And like you said, we had many medical issues, and I think luckily we were sent a letter from the newborn screening about it, and which reminded me, but I don't recall off the top of my head that our pediatrician reminded us, and he was the director of the NICU at the time. So maybe he did, and I'm just not remembering that, and maybe we were just so frantic with so many other health issues at the time that maybe, so, but I wonder too, for parents who have children with cognitive disabilities and hearing loss, I think sometimes they don't either get from the primary care doctor, pediatrician, etc., still that urgency to get it done. And I think there is a great urgency to get it done. I've seen my daughter does so much better with her hearing aids in. And so I don't know if it's educating families, providers, people in the hospital, and just that continuation of somehow getting information to all of those people of how important it is. And then something else, last but not least, to think about is how anyone working with that family, anyone that is on that team, can really help that family help get speech therapy, whether it be through the school or privately, because many You know, they cover so much through insurance, children's special health care, or Medicaid. If you have a cognitive disability, it may need to be worded differently, because anything with hearing loss, somebody should be able to get, not physical therapy, I apologize, speech therapy. But sometimes it's not seen as, especially in the school, well, she already has intelligibility issues because of, I'm talking about in regards to my daughter and what I've heard through speech therapy at school, due to her, you know, mouth structure, the low muscle tone, etc. So I don't really understand why we need it, and I actually had the audiologist from send, okay, this is why she needs it. And so it is frustrating for parents, but thank you again, and I hope some of what I shared with you is a little helpful.
Yes, thank you. Just to your last point, I think that one of the challenges for children who have cognitive issues or other comorbidities that might impact their speech and language development or how they respond to sounds, I think unfortunately, I think the lack of development gets blamed on automatically the cognitive impairment as opposed to thinking about the impact of the hearing loss. And I think, you know, that's the thing that's really a shame. And that happens with autism too. I think there's a relationship between autism and hearing loss. And I think if autism gets diagnosed first, then hearing loss might get diagnosed late and vice versa. So I think that's one of the beauties in my mind of this LEND program, of having us all learn together about these factors and my hope is that by learning together we'll be more effective teams and be able collectively to provide more education to the other folks who are interfacing with our children or the children that we're serving. I really appreciate your comments.
Thank you.
All right. Well, thank you so much. Again, there's a wealth of information that Carissa provided for you in your information on Blackboard for last week that applies to what we've talked about today. So I would encourage you to take a peek. And again, both the CDC site and the ASHA website have lots of information, including links to articles and things like that that you might find valuable. And with that, I think it's 7 o'clock, and so we can conclude the session.